Can we have the recorded talk of Dr. Rajesh FOGLA?
We request the audiovisual team to please screen the recorded talk by Dr. Rajesh FOGLA. He could not be here with us physically. His talk is on approach to Pterygium.
I shall be talking about a common clinical condition, pterygium, and how you approach it in your clinical practice. I have no financial interest to disclose. Pterygium is a triangular wing-like growth consisting of conjunctiva and hypertrophic subconjunctival tissue. Commonly occurs in the palpebral fissure, mostly in the nasal quadrant. It may start initially as a pinguicula, and in advanced cases, it can encroach onto the cornea. Pterygium consists of a apical cap, head, and a large body. You can see a pigmented line in front of the apical cap. It is called the Stocker's line. You have the head, that's the encroachment onto the cornea, and what you see on the conjunctiva is the large body of the pterygium. The overlying conjunctiva may be normal, or it can show acanthotic, hyperkeratotic, or dysplastic changes, while the underlying stroma shows elastotic degeneration and the abnormal collagen fibers produced by the damaged fibroblasts. There is an increased prevalence around the geographic equatorial belt, possibly due to increased UV exposure, slight preponderance in males who work outdoors. It's more with increasing age, and it has been noted that colored skin has a 2.5 times risk of developing pterygium. Increased UV exposure is the most common reason. Reflection of light from the nasal bridge could be the reason why a nasal pterygium is seen more frequently. Further contribution occurs with the exposure to the sand and dust, resulting in the microtrauma, the wind, and the desiccation of the interpalpebral area. There can be a hereditary or genetic predisposition. Immunohistochemistry analysis shows overexpression of p53 gene, suggesting role of dysplasia. Focal limbal stem cell deficiency may be associated with encroachment on the cornea, and there possibly is an additional role of human papillomavirus in the etiopathogenesis of pterygium. Clinical presentation can vary from the patient being asymptomatic or presents with irritation, foreign body sensation, dryness in the eye. A decreased vision can occur from induced astigmatism, or if there is encroachment of the visual axis with advanced cases of pterygium. Recurrent pterygium may also cause a double vision in different positions of gaze. Patients can also present for cosmetic regions when the pterygium gives a reddish, fleshy appearance. The grading of pterygium can be based on the extent of corneal involvement in terms of how many millimeters it encroaches onto the cornea, or it can be graded with the density of the pterygium, that is how well you can visualize the underlying structures. So in atrophic pterygium, you can see the underlying sclera, whereas in a very large fleshy pterygium, the structures may not be visible. You can also classify it as primary pterygium or a recurrent pterygium, or a classical pterygium and a pseudopterygium, which can occur following chemical injury or peripheral ulcerative keratitis, when it can be at any location, not necessarily in the interpalpebral area, and usually they are non-progressive, and in some cases you can pass a probe underlying the pseudopterygium. You can have a single-headed pterygium or a double-headed pterygium. Differential diagnosis includes pseudopterygium, as we just described, limbal dermoid, flictennular conjunctivitis with the hypertrophic conjunctiva, ocular surface neoplasia, conjunctival lymphoma, or sometimes with nodular scleritis or sclerokeratitis. All these when they occur in the typical nasal or temporal location, it can be misdiagnosed as a pterygium. This flowchart gives an overview of the management plan of dealing with pterygium. Various techniques of surgical excision have been described, including the bare sclera technique, excision with primary closure, use of antimitotic adjunctive therapies, excision with ocular surface reconstruction using conjunctival or conjunctival limbal autografts with or without amniotic membranes. Bare sclera excision technique was described in 1948 by O'Brien. A simple excision of the head and the body of pterygium is performed without any closure. This technique has a very high recurrence rate ranging from 24 to 89%. And because you leave the sclera bare, there's increased chances of complications, scleral necrosis, scleral infection, and sometimes often leading to symblepharon formation and diplopia. Therapy using strontium 90 were attempted, which did reduce the recurrence rates down to almost 10%, but were often associated with complications like scleral melts, infections, cataract, dry eye, ocular surface disease due to limbal stem cell dysfunction. Use of mitomycin C, an alkylating agent, is commonly used in glaucoma surgery. It has also been described in the management of pterygium and has been applied preoperatively by injecting mitomycin C 1 month prior to the excision, especially for fleshy pterygium. The recurrence rate reported has been about 6%. Intraoperative application of mitomycin C 0.02% for 30 seconds to 5 minutes have been described, and recurrence rate vary from 3% to 43%. It can often lead to delayed conjunctival healing, corneal endothelial cell loss, and scleral or corneal melting. Postoperative use of mitomycin C in the form of drops, like BD or QID for 1 to 2 weeks, in an attempt to reduce the recurrence rate, has been tried. Again, the recurrence rate varies from 0 to 38%, but again, the complications of scleral melting, scleral or corneal perforation, secondary glaucoma, cataract, all have been described. Mitomycin C, the alkylating agent that inhibits cellular division by inhibiting cellular DNA and RNA, sometimes has a long-lasting effect. And because of this delayed healing, it can result in scleral melts, associated perforation, and at times it can also lead to infectious scleritis as well. Pterygium excision combined with ocular surface reconstruction using conjunctival or conjunctival limbal autografts is currently the procedure of choice worldwide. It's associated with the lowest risk of recurrence, minimal risk of complications, and excellent cosmetic outcomes. It can also be combined with amniotic membrane transplantation when dealing with recurrent pterygiums. Randomized clinical trials comparing conjunctival limbal autografts to mitomycin application or amniotic membrane transplantation alone have shown better clinical results with the use of conjunctival limbal autografts. This clinical photograph shows the outcome of a conjunctival autograph following excision of a pterygium, and the autograph was secured using 10 nylon sutures. Fibrin adhesives are biological and biodegradable, consisting of two components, fibrinogen and thrombin, which on combination form an adhesive fibrin. Advantages include shorter surgical time, greater patient comfort, and reduced recurrence rates. However, it's expensive and also has the risk of getting contaminated. Autologous blood has also been used successfully for the same purpose, and it may be a reasonable alternate. cornea looks very clear. On topography, you can see that the pterygium was inducing almost 11 diopters of astigmatism. So it's usually like a with the rule astigmatism because there is horizontal flattening. And after excision of pterygium, that astigmatism has dropped to about 0.7 diopters. The perfect technique, which stands for pterygium extended removal followed by extended conjunctival transplantation, was described by Laurie Hurst from Australia. Has 0% recurrence rate for primary pterygium and 1% for recurrent pterygium. Now, in this surgical technique, a large area of conjunctiva is also excised along with the pterygium, extending all the way to the caruncle. And then you prepare a conjunctival graft and cover the entire bed. This also gives very excellent cosmetic outcome, and the recurrence rate in a large series of 250 eyes with a follow-up of 1 year was noted to be 0%. In the post-operative management, we use topical antibiotics at least for a week or two till there is complete both corneal and conjunctival epithelial healing. And topical steroids can be used for 2 to 3 months in tapering dosage to control the surface inflammation, but watch out for steroid responders, so monitor the intraocular pressure. Topical lubricant eye drops can be used for an extended period of time for 3 to 6 months, and we advise the patient to use UV protection sunglasses while they are outdoors. The follow-up typical schedule is on day 1, day 5, to day 14, 1 and 3 months. What are the complications? You can have graft edema, hemorrhage under the graft, the Dellen formation. If the graft is swollen, then the adjacent cornea can become dry. You can have displacement of the graft or retraction. That's why I like to put stay sutures at the limbus. You can have loss of the graft. Donor side, you can have sometimes formation of Tenon's granuloma. Sometimes it can also occur at the edges in the site of excision. And obviously, you have the recurrence of pterygium. This nice paper from Harminder Tua, they looked at the healing of the conjunctival grafts, and they found that yes, you do get retraction at the edges. You can get that serous fluid under the graft. This, if it occurs, you can just puncture the conjunctival graft using a needle to release the fluid. You can have hemorrhage, and sometimes you can have the formation of granuloma. How do you manage recurrence? By doing a meticulous primary surgery so that there is no recurrence. In the early stage of recurrence, you can try increasing the frequency of topical steroids or giving sometimes subconjunctival 5-fluorouracil or anti-VEGF injections. And if none of these work, then you have to do a repeat surgery, and at that time you can use a topical mitomycin C application, or if you are short of conjunctiva, you can also combine it with amniotic membrane transplant. So basically, in conclusion, pterygium is a common disease in the tropical belt, and in advanced cases often requires surgical excision. Conjunctival autografting is currently the gold standard for surgical treatment. Meticulous surgery and the use of fibrin glue can reduce recurrence rates and give excellent cosmetic outcomes. Intraoperative mitomycin C application has a role in recurrent pterygium surgery. Amniotic membrane transplantation has an additional role in surface reconstruction, especially in recurrent cases where it requires extensive removal of the pterygium and you have a large stromal bed that you need to cover and requires longer time for resurfacing with conjunctival epithelium. Thank you for a patient hearing.